Welcome to the RadOnc Virtual Visiting Professor Network. Today we have a Radiation and Lecture Exchange Series program with speaker Dr. Mel Chua from Singapore discussing chemoradiotherapy for nasopharynx cancer. Today's moderator is Dr. Karam. In the first part of this lecture, you'll hear everything from the incidents through the randomized trials addressing induction chemotherapy in this setting. Hope you enjoy it.
It's a great pleasure to introduce my friend and someone who has the highest level of my respect, Dr. Chua, who is a clinician scientist at the National Cancer Center in Singapore, or National University of Singapore. And I thought it was also interesting that he serves as a visiting professor at the Wuhan hospital. We all are familiar with that now. He is a principal investigator of trials. He holds several grants. He did his PhD at the University College in London. We all are familiar with that. He's very prolific, publishes in the field, and has published some game-changing articles, and that will definitely integrate into our standard of care. So I'm very, very proud of the work that he does. He also trains many residents, and he has a full lab of many scientists who are defining the future of our field. It is really a great honor, and I am so glad that we have this platform, especially in these crazy times, to allow our field to cross-fertilize. And without further ado, I will let Mel take it from here.
So again, thanks so much to Sana and Brian for inviting me to speak at this forum. I mean, it's surreal. I mean, this is, unprecedented times. But again, is this sort of virtual platforms that have sort of really lowered the barrier to sharing and, academic exchange. And it's 9 p.m. over here, and I just got a full day of clinic. So I hope that I'll try to talk some sense about what I'm sharing tonight. Feel free to raise any questions, but I hope it is intended to be a sharing of experience, interspersed with some of the thinking behind the evidence that has been generated specifically for nasopharyngeal cancer, and where do we see the field moving forward. And I thought the best way to always attract people to come to talks is to give a semi-appealing title. And as you can see, there's several terms of references as to why I chose this title of A Hobbit's Journey There and Back Again. And it relates very much to the position of Singapore and my institute specifically, NCCS, and how we were one of the early pioneers in the trial landscape on MPC, and how also we have influenced in a small way, and how the treatment has evolved in the last 2 or 3 decades. So without further ado, this is my disclosures, nothing particularly related to the talk today. And so this is a familiar map that outlines the distribution of MPC across the world. So you'll see that there is a very distinct geographical distribution, where this cancer is very much densely affecting people in the Southeast Asia, and in fact in the northern part of Africa, there's also a endemic subset of MPC that arises, and in fact in America itself, in the northern parts, especially in the Greenland, in the Alaska, we also do see a prevalence of MPC, and in a way that relates to why this cancer was known as Eskimoma at one point in time. Now, the MPC that we see in these endemic regions, they differ very much from what you may be familiar with in North America, in parts of Europe, where while you may get the squamous cell carcinoma variant, that's more common, but really in our region we see a undifferentiated subset, and sometimes we may see what we call this non-keratinizing epithelial tumors, but almost invariably they are associated with Epstein-Barr virus. Now, if you look at the trends, however, in some of these regions where this disease was previously endemic. So here I just showcase the incidence in Hong Kong. So this is a paper by Anne Lee herself. The data was was more than 10 years ago, but still, the trends are generally decreasing in Singapore and Hong Kong. But it's still, sort of holding at a steady state. And you see this is the Singapore registry data, and which is updated every 2 years. And while again you see highlighted in the green line the downward trend, but largely in the last sort of 5 years or so, it has remained stable. So we still do see a high prevalence of this cancer among the head and neck cancer subset that we see locally. Now, interestingly, in China, specifically in Guangzhou, where this cancer is extremely prevalent, the numbers have held pretty steady. And you'll see why this actually matters in terms of how it has motivated and facilitated the ever-changing trial landscape for this disease. Now, the reason why I sort of put up this Hobbit notion is that really, while we were one of the early movers in the trial landscape, when we compare ourselves to what China is and the number of trials in this space that come out from China, you appreciate that we are really a very small population and a small group of trialists that's trying to stay relevant in the against a much sort of stronger competitor where they see a lot more cases, and that's really where I see ourselves as a very nimble sort of 34s that's trying to sort of think about the new treatments in this disease and how do we actually design a new generation trials. And while I say while we have the Singapore landscape that is certainly impressive, what they have in China are sprawling cities of the cities. And, again, the notion here is to emphasize the competition, particularly in designing trials for this disease. Now, one of our pride, has really been the fact that we were able to run 2 randomized phase 3 single institutional trials. And I showcase the predecessors here before my time. On the left is the trial that was published for more than 20 years now, and this is one of our early dabble into trying into the clinical trials in this disease, and it's followed suit after the Australop that was published, and it was led by 2 of my predecessors, Dr. Tang En Huat and Dr. Joseph Wee, who were the early thinkers, whereby they simply adopted the Australop regime and tested it in our local population. At the same time, Dr. Terence Tan here and Dr. Darren Lim, on the backbone of the trial that was done, more than 10 years ago, were again, able to conceptualize and complete a trial against a single institution trial looking at induction chemotherapy in this disease subset. And here, I'll talk more about the trials later on, but the combination that was used here is a triplet combo comprising of gemcitabine, carboplatin, and Taxol. And we know that this data is essentially, this trial is a negative trial. So, the first trial, while we were very fortunate in proving that more chemo against radiotherapy alone was able to reduce the onset of distant metastasis, leading to improvement in overall survival. We can see here, this is the chemo arm, this is the RT alone arm. And this early impact on survival really changed the standard of care for this disease, and really transferred the knowledge that was gained from the Australop trial done in the US to the parts of the world where this disease is endemic. But unfortunately, while we were able to lever on the early, while we were able to write on the early success, this did not translate to the second trial that we ran, whereby disappointingly, induction chemotherapy did not improve disease-free survival, and we didn't see any difference in overall survival. And I'll sort of share some of our insights as to why that may be the case. Now, but this really emphasizes the point as to, now that despite the fact that we have done, we've been lucky in a way to conduct single institutional phase 3 trials, but in this ever-changing landscape whereby we see this, this is increase in incidence of nasopharynx cancer, particularly in south of China, we start having to think of, how are we able to run, how are we going to sort of stay relevant in designing clinical trials and MPC. And this is a slide that I, really emphasizes this point. So this is data from Junma, whereby essentially they've shown that in just a single institution in Sun Yat-sen alone, whereby they see up to 5,000 nasopharynx cancer per year. And granted, nasopharynx cancer may not be the most common cancer in the whole of China, but the fact that it's even more, they see more cases of this than lung cancer or all the other more common cancer types, essentially emphasizes that, this is a single institution where just by sheer volume, they would be much faster and able to push trials through and to be able to recruit patients and complete trials. And so, this is extremely, important in terms of how we see ourselves, trying to stay relevant against an institution powerhouse where, running clinical trials became a core academic mission. And so, this is where I take a pause and I'll bring us through the whole story of how it all began in terms of the treatment of nasopharynx cancer, and then how it evolved from adjuvant chemotherapy to where we are today, where we see an increase of induction chemotherapy, and that being the standard of care. Now, we're all familiar with the Australop trial. It was published, more than 20 years now. And it essentially defined a new standard of care. It made the East stand up and recognize the need whereby we should test this regime in our population. And this trial was a very neat trial where he essentially compared concurrent chemotherapy followed by adjuvant cisplatin and 5-FU against radiotherapy alone, showing that more chemotherapy was able to improve tumor control, specifically in reduction of distant metastasis, as evident here, and we know that resulted in improvement in overall survival. Now, it is not untrue that induction chemotherapy is something new, because in fact, in the same time period, there were 2 trials on induction chemotherapy alone. Now, this was not followed by concurrent chemoradiation, so that there are little nuances in terms of the difference of the trial. But what we have here are 2 trials that were done in the same time period. One on induction BEP, so it's bleomycin, etoposide, and platinum. So it's epirubicin and platinum, which is not used, to date anymore. And another trial from Hong Kong, looking at just epirubicin and platinum. Now, compared against Australop, where it was an overwhelmingly improvement in survival, there was no difference at all in terms of overall survival for both of these trials when induction chemotherapy was applied compared to just radiotherapy alone. So on that note, one could argue that at the time, induction chemotherapy certainly took a huge beating in nasopharynx cancer compared to the Australop regime. Now, this alluding to the point I made earlier, this really kick-started a whole slew of trials that were done in the east side of the world. So here I essentially highlight the different trials, and you'll notice right away that they were different regimes were used. Ourselves included, and the group from Hong Kong and the group from Guangzhou adopted the same trials treatment regime as Australop, whereas some groups in Taiwan and Hong Kong adopted other regimes where they just looked at concurrent chemotherapy alone. Now, regardless, what was clear from all these trials were that more systemic therapy improved overall survival in this disease, which made sense because we know that patients relapse primarily through distant metastasis. Now, but it's important to consider that these trials were done during the era of 2D radiotherapy. So, at the time, certainly in a disease where radiotherapy is the primary modality, local control was still suboptimal for bulky T3, T4 disease. And so what you see here is that while we see a signal for distant metastasis, for example, like our trial and some of the other trials just on concurrent chemotherapy alone, the improvement in distant metastasis was not across the board. For example, like in the trial from Hong Kong, the effect was much less apparent. But the improvement in survival seems to be attributed to an improvement in local control. So I think, at a time, certainly, what in the era of 2D radiotherapy, chemotherapy had more far-reaching benefits apart from just controlling of occult metastasis. Now, obviously, we've since moved on to conduct, look at aggregated data from the individual patient pool data from the different trials. And this data is 5 years old now, and I'll present some updated analysis later on from the Mark meta-analysis group. And thanks to Jean-Pierre Pignon and Pierre Blanchard, who have taken over the helm of this group and be able to show that chemotherapy thus improve survival. And here, although it's not a good sort of one-to-one, hit-to-hit direct comparison, but it would seem that if you just had concurrent chemotherapy alone, looking at just overall survival at 10 years, compared to more chemotherapy after chemoradiation, more chemo certainly seem to be better in terms of overall survival advantage. Now, the beauty of having a large amount of data at the individual patient data level is that you are able to then look at specific, clinical benefits from the different strategies. So this is a exploratory analysis looking at the different sequencing. So you have induction here, adjuvant chemotherapy alone, concurrent alone, and concurrent plus adjuvant. And you see that while the concurrent and the concurrent plus adjuvant yielded a overall survival advantage, it does seem that induction does have some benefit for distant control, and adjuvant may have some benefit for local regional control. But again, that has to be taken in the context that the majority of the trials that were analyzed in this analysis were done in the 2D era. But there were issues. So while we understood that there was some, a differential benefit from the different sequencing strategies, but yet in the community there were two camps, and each advocating for the fact that we may not need more chemotherapy, that concurrent chemoradiation was sufficient, and I'll sort of deep dive into some of the reasons why there was a concern with adjuvant chemotherapy. And the same group published a network meta-analysis. Again here, so in a network meta-analysis, it is a more unique way of looking at indirect comparison, but allows you to at least infer if one treatment strategy is better than the other. So it's important to understand that this hazard ratios here are an indirect comparison, but just judging by this network analysis alone 3 years ago, it would suggest that if you gave adjuvant chemotherapy after chemoradiation, it was still somewhat better compared to just chemoradiotherapy alone. Now, just to move on ahead, so what's the issue of adjuvant? And here in this table here, I summarize, all different trials, those that use adjuvant chemotherapy and those who did not. And you'll appreciate that, yes, majority of the trialist group use the Australop regime. The group here from Hong Kong, led by Dora Kwong, use a more sort of intensive, sort of innovative regime, which again comprises of drugs that we don't often use today. But if we just focus on this table here, it is clear that even in a select group of fit patients, very few of them could actually go through a good number of cycles of adjuvant. And that remains the case if you look at the newer trials. So across in the Australop trial, only about 60% of patients were able to receive 2 cycles or more. Likewise, in the Singapore trial, in the Hong Kong trial, kudos to Ann Lee and her investigators, they were able to get a good proportion of patients to receive at least 2 cycles of adjuvant chemotherapy. But by and large, in most of the other trialist groups, there were issues. And if you think about it, I mean, it's not, it is not implausible, because after a very toxic course of chemoradiation, it's tough, for patients to receive more chemotherapy. And so, across the board, in such a select group of patients whereby we see that, if you give chemo after chemoradiation, you might potentially compromise on dose intensity, then we certainly have to think of a way whereby we need to intensify systemic therapy. Because ultimately, especially in the IMRT era, where we see such good local control now, even for advanced patients, then we need to think of innovative ways to intensify systemic therapy so as to optimize control over occult metastasis, which is the key pattern of failure. Now, as I sort of might have alluded to earlier, it's not as though adjuvant chemotherapy has not been done. We saw in the marked meta-analysis that adjuvant chemotherapy might have some benefit on local regional control in the 2D era. But there were trials that actually were designed to specifically address this issue. If we gave chemotherapy after radiation, will that actually help in terms of improving control of distant metastasis? So you can see that the Italian trial, all these trials essentially showed a negative result. I include some potential reasons here, and again, these are purely my own hypothesis. So don't take that as gospel truth. But I just want to focus specifically on the Sun Yat-sen trial, the more contemporary trial that we all might be familiar with. So this trial was a very clean trial, whereby led up from Guangzhou, and this was the perhaps the first trial which led by Sun Yat-sen that really stamped their mark on the clinical trials landscape for nasopharynx cancer. And it was a very clean design and a very clean question, where they simply asked if I enrich for a very high-risk cohort, so not just stage 3 or 4 nasopharynx cancer patients, but rather patients with T4, T3, T4, no positive disease, or even if it's a small T tumor but bulky N2-3 disease, then for this group of patients where we know that they have a high propensity of occult metastasis, then what would be the benefit of more chemotherapy? And essentially, it's testing the Australop regime against just chemoradiotherapy alone. Now, we saw their initial results at 2 years, and at the time, if you were a naysayer that there was no overall survival advantage, one could even still argue that potentially you see this separation in this PSF curve, which was the primary endpoint. And you see this tiny separation with distant control, no separation with local regional control. And one could argue that perhaps the data wasn't mature at the time to detect this survival difference. Now, the other thing that I indicate here as a limitation was sample size. Now, I suppose if you then look at how the trial was designed and how the power was calculated, it was surprising to many of us that even in this very adverse, unfavorable cohort of patients, that the control arm did pretty well at 2 years with a control rate of 84%. So, clearly with perhaps improvement and advances in radiotherapy and, a more contemporary group of patients who may be fitter and so forth, and that might have just pushed the bar in terms of, the benchmark for controls, for survival rates of controls, and in a way that the trial might have been underpowered to detect a difference. We've seen the updated data more than 5 years later, again confirming that that even with longer term follow-up, there's absolutely no difference in terms of disease control. And you can see here with a large majority of the patients having more than 5 years follow-up now. But the thing with this trial is the same, that if you look closely at the compliance to adjuvant chemotherapy, likewise to all the other studies, despite selecting for a very fit group of patients a good majority of patients were unable to complete adjuvant chemotherapy of 3 cycles. And 50% of them actually had a dose reduction and 70% of them had delays. So again, emphasizing the need that if we are to give more chemotherapy, we need to be creative about how we do it. So I will take a pause here and share some thoughts on where I think what might have been the pitfalls of adjuvant chemotherapy, and how we might do things better going forward. So I think despite having enriched for patients that we think are at high risk of metastasis, the truth is, are we really selecting the right group of patients? Are clinical indices sufficient for us to enrich for patients that are at risk of distant failures? Are there things that we can layer on top of clinical indices to select patients better? Now, are we selecting the right drugs? Is adjuvant, platinum and 5-FU necessarily the best way to tackle this chemo or radio-resistant tumor clones that are likely to escape, intensive treatment upfront and recur in the bones and the lymph nodes and the liver after that? And then finally, are we selecting the right regimens? And I'll showcase some of the trials that are some of them completed, some of them ongoing, that may look at innovative solutions on how we can, change the delivery of adjuvant chemotherapy better. So I'll take a pause here, and then sort of shift gear into how we have evolved from the early days of the trial, and the early gains that were made with more chemotherapy, then obviously the setback that we had with adjuvant chemotherapy, and then transitioning to the Middle Earth. And if you guys are familiar with the Lord of the Rings, you'll know that this essentially is the sequel of the Hobbit. And I think relating to this, we know now that again, it's efforts from the Sunetson group, and we are fortunate to be part of it, whereby it's the shifting gears of moving the chemotherapy up front, and how that has now been the new standard of care. So if we then look again at the VUMCA trial, so this is the trial I showcased earlier, so led by Szyszkowicz, and Szyszkowicz actually is a massive pioneer in this field, because he was one of the early academic who was a forward thinker into use of cisplatin in head and neck cancer. So while I've chosen to show you the overall survival curve showing no difference for the VUMCA trial when it was presented in 1996, in fact, if you look at the disease control, there was actually a separation of curves with if you use induction triplet upfront with just radiotherapy alone. But of course, we saw that in terms of translating the survival, this did not pan out. But again, that was very sort of early data at that point in time, and unfortunately, there was no sort of updated data from that group subsequently. Now then, if we dive a bit deeper in the trial from by Mel Chua from the Hong Kong group, whereby they had just used, instead of the triplet, they used the doublet of cisplatin and epirubicin. You see that in terms of relapse-free survival, there was no difference. But then when they dug deeper into subgroups, they found that, again, obviously this is unplanned exploratory analysis and should be interpreted with some level of caution. But when they enrich by some arbitrary cutoff of a lymph node size of more than 6 centimeters, and at the time, this would be considered N3 disease, and patients with a bulky neck node will have been considered to be at risk of distant metastasis, you do see a potential signal for induction chemotherapy. So this led to potential hypothesis that perhaps we should not throw the baby out of the bathwater, that induction chemotherapy might actually be a way to go in terms of helping us deliver more chemotherapy. Now, this is a summary of all the trials done on induction chemotherapy in advanced NPC. So This is a review published by Dr. Chen from the Sun Yat-sen group, as well as Jun Ma, who's an active trialist, and Quinn, who's also on this paper as well. But they did a very nice summary of all the induction trials done to date. So this was just published in the Lancet last year. And despite this, I mean, the reality is that induction chemotherapy took a huge beating. And it took almost a 10 plus year gap before we could actually see the emergence of positive results. So, I chose those to highlight here because after these two negative trials that I showcased, in fact, there was a phase 2 trial, a randomized phase 2 trial led by Anthony Chan in CUHK and Edwin Hui, whereby they showed that just 2 cycles of doublet chemotherapy, here it was induction, docetaxel, and cisplatin, followed by concurrent chemo, radiotherapy, and what they used in the trial was weekly cisplatin. They actually showed a dramatic difference in disease control of 94 versus almost more than 20% difference. And this translated to a quite a substantial survival benefit, although it was not statistically significant, but granted it was a randomized phase 2. But 2 other trials led by the HECOG group, it was a randomized phase 2, showing that while there was a benefit for disease control, there's absolutely no benefit in overall survival. And the trial from Singapore, which was a randomized phase 3, looking at triplet chemotherapy, and there was absolutely no benefit for disease control. You can see here against disease control here and overall survival. Now, what may be the case for why the trial done from Singapore was actually a negative trial? So we published the first report more than 5 years now in the Rate Journal, and this is a trial schema. So we recruited patients with stage 3 or 4 nasopharynx cancer. We stratified them by the nodal status. So you had, we stratified by N0 to 1, N2 to 3. It was a 1-to-1 randomization whereby patients received triplet GCP. So to clarify, it was gemcitabine at a conventional dose, carboplatin at AUC of 2, and Taxol. And then the patients received 3 cycles of this, followed by weekly cisplatin, compared to just weekly cisplatin alone. Now, it was, when we designed the study, it was powered at a sample size of 172. But when we looked at our initial results, we were somewhat surprised at how well our patients actually did. Now, ignore the 5-year DFS, but if you just look at the 3-year time point, I mean, for the control arm, we had achieved almost, more than 70% disease control rate, and that was similar in the patients who received more induction chemotherapy. And more impressively, if you look at the overall survival at 3 years, I mean, this was above 80%. So suggesting that we was, without even doing anything, just by delivering the same treatment, we were already achieving benchmarks of survival that was already far exceeded what we observed in our first trial, that was done in 2005. And, the advances could have been brought by IMRT, better staging and so forth. And we've looked at our mature results. This has not been published, but it's been included in the meta-analysis. And essentially, we still do not see the difference. Now, one of the main reasons was when we went back to look at the patient population that was recruited for the study, we realized that we might have made the unforeseen sort of oversight of recruiting patients who were mostly N0 to 1. And in fact, N2 to 3 constituted a very small proportion of our study cohort. So in a way, we might have selected patients that were actually at low risk of distant metastasis to begin with. And for these patients, perhaps just chemoradiotherapy alone would have been sufficient. So we did further exploratory analysis, and at the time we had EBV DNA measured for a subset of patients in the trial. I believe it was about 60% of the patients on the trial had EBV DNA measured for 112. I presented this data 6 years ago at ASTRO annual meeting, But just to emphasize here, so these are patients stratified by detectable EBV DNA alone versus undetectable EBV DNA. And you can see that patients with a detectable EBV DNA had a higher likelihood of, had a sort of slightly higher risk of distant metastasis. Treatment did not seem, the difference was not statistically significant. But when we try to examine for a treatment effect by EBV DNA, whether it was detectable at baseline, that is, those prior to induction chemotherapy, we observed, anecdotally in a very small group of patients with limited events, that if you had a detectable EBV DNA, then you might have benefited from more chemotherapy in terms of distant metastasis control and not for local control. And if there was no EBV DNA detected, then these patients essentially had a very low risk of distant metastasis to begin with. We did further sensitivity analysis by cutoffs, so looking at 4,000, 6,000, and it would seem that for patients who had more than 6,000 copies of EBV DNA, which would imply that these patients had a higher risk of occult metastasis, then these patients would have benefited from more chemotherapy as opposed to patients with a lower burden of EBV DNA. Now, of course, we could look at these numbers and say they are highly exploratory, and that's indeed the case. But adding on to this work, there's now a very nice paper which I won't show in my talk today in the interest of time. That was done out by the CUHK group in collaboration with Sun Yat-sen, whereby they've actually shown that EBV DNA after chemoradiotherapy, by just looking at the titer of itself, they were able to stratify for patients based on the load after chemoradiation, whereby patients with a higher EBV DNA load, they were actually much worse in terms of risk of relapse compared to patients with a lower EBV DNA load after chemoradiotherapy, and perhaps this would be the group that would benefit from more systemic therapy. So again, doesn't mean that you have a detectable EBV DNA at the end of chemoradiotherapy means that you are a poor player. That within this subgroup, you can further stratify patients into more granular groups. Now, then fast forward. Right after our trial, the Sun Yat-sen group then published on their Induction TPF data. We know the data now. I won't go into the details of it, but just to emphasize one of the key points here, essentially this was a liftoff from the induction chemotherapy trials that were done in head and neck squamous cell carcinoma at the time. You can see here, whereby they use a much higher doses of TPF, 75 milligrams, 75, 750, whereas in that MPC trial, and the rationale being that in a Asian population with smaller sized patients, the investigators were concerned that this study cohort would not have been able to tolerate such a high dose intensity of TPF. But using 60, 600, dose regime of TPF, they were able to show that in fact induction chemotherapy, in contrast to the data from the head and neck squamous cell carcinoma trials, was able to yield a benefit in terms of disease control, failure-free survival. And this enhancement at a 2-3 year mark was able to lead to an early overall survival signal at 3 years. And we have, and this benefit appears to be localized to distant metastasis control. The majority of the trial, about more than 2/3 of the patients in this trial were treated by IMRT. So this contrasts the earlier MPC trials whereby most patients were treated with still 2D era radiotherapy, and you start seeing that there was less of a benefit in terms of systemic therapy for improving local regional control, given the better RTQA in this more contemporary trials. The updated analysis published last year continues to show a survival benefit, whereby you see this this benefit even up beyond 5 years, and likewise for survival. But certainly, if you look at the overall survival for this trial at 5 years, we're looking at a very high benchmark for advanced stage 3-4 NPC patients, whereby just by chemoradiotherapy alone, you're still achieving a more than 75% survival rate at 5 years, even for a very aggressive subgroup of patients who are supposedly at risk of distant metastasis. Now, the issue with TPF, despite the positive data from this trial, was that likewise to what we saw in the Induction TPF trials in the head and neck squamous cell population done in the West, was the high rates of severe toxicity. And the thing is, despite using a lower doses of TPF, we're still seeing a much higher grade. Like in that trial, 18% of grade 4 toxicity compared to just 1% in the control arm. And as we would expect, the majority were attributed to severe hematological toxicity. So and that despite this positive result, sort of was the main hindrance for the uptake of this treatment regimen. Even in the endemic areas where just very few patients were able to tolerate induction TPF, certainly up to 3 cycles. So at a time, we at the same time when this trial was reported, we saw the publishing, we saw the results of this other phase 3 trial that was done in M1 NPC. Now, this trial was seminal and pivotal for a number of reasons, but the main reason being, and you wouldn't believe that this was the first randomized phase 3 trial that was done in metastatic NPC. So prior to this trial led by Professor Zhang Li from Sun Yat-sen, as well as my good colleague Xie Chonghua and Zhao Chong, there was not a single randomized controlled trial in stage 4 NPC. Now, I was fortunate to review this trial, and at the time, this was a very simple design, whereby we knew for a while that gemcitabine cisplatin as a doublet was more efficacious than PF, but no one ever did a head-to-head comparison, and this trial essentially proved to us that GP yielded much better response rate, and we have seen the data from this trial now, and this improvement in response rate of more than 60% against PF, you see here where you get much lower complete, certainly no complete responses and partial response, and this early signal in tumor cytotoxicity led to improvement in progression-free survival and overall survival. But anecdotally, we observed that GP as a doublet, was very tolerable among M1 patients. So this, really brought to mind at a time when I wrote the editorial. My thinking was that gemcitabine was likely going to be a game changer in NPC, and you will see that how whether this drug could actually change how we the treatment landscape in the locally advanced setting. And so that prompted us to launch this other randomized phase 3 trial that I was fortunate to be part of. Again, kudos to Junma featured here and his fellow investigator Sun Ying, and they are, the two of them are literally powerhouses and partners in crime in terms of leading large-scale randomized trials in NPC, and they were agreeable to essentially kickstart this next randomized phase 3 right after the completion of the Induction TPF trial. And again, it was a very simple design. Now, a few things to note here, that despite that we see the obvious thing whereby patients are treated with 3 cycles of gemcitabine cisplatin at conventional doses. We took the initiative to actually switch from a weekly cisplatin 40 milligrams per meter square to a 3-weekly regimen. And we believe that might have been one of the reasons why this trial was actually positive, and I'll explain why. Now, if you had noticed that in the Induction TPF trial, the concurrent arm was actually weekly cisplatin 40 milligrams per meter square, and likewise in the Singapore study, it was also 40 milligrams per meter square. The patient cohort that was recruited again was enriched for occult metastasis. The study was designed, with recurrence-free survival as a primary endpoint. Again, one could argue why we hadn't gone with overall survival as a primary endpoint. The idea was that with such a high benchmark for overall survival, as we have noticed in the newer trials, that would have led to trials sample sizes that would have been quite difficult to achieve. And at the same time, we had actually, in collaboration with the Mark meta-analysis group, published on how recurrence-free survival was in fact a very good surrogate for overall survival in locally advanced NPC. So and hence why this was set as the primary endpoint of the study, and the secondary endpoints included overall survival, distant metastasis control, local survival, and so forth. Now, we presented the data last year, and that was after a very sort of thoughtful analysis of the trial results, and we recruited 480 patients. This was the time period, so it was we were able to complete, and the trial was essentially led out from China, where they was just so aggressive in recruiting patients for clinical trials, and patients who go there are equally motivated to be part of these trials. They were able to complete this nearly 500 patient trial in 3 years, but it was important that that we had patients who had adequate follow-up. So when we decided to report the data, close to 70% of patients actually had follow-up of more than 3 years. And again, this was born from the experience of Professor Junma, who was a keen investigator, and he knew from his prior experience that we just needed enough patients to be followed up for the X amount of time, whereby there will be sufficient events to actually detect a signal if we were to see any between the 2 treatment arms. Now, equal number of patients were recruited, and you can see here that impressively, more than 95% of patients actually received 3 cycles of induction gemcitabine cisplatin. If only 3.3% who did not complete 3 cycles. Now, if you look at the concurrent arm, almost all patients completed radiotherapy. Now, just to emphasize here, we were able to at least, got a good number of at least half of the patients to complete 2 cycles of concurrent cisplatin. But you see this massive drop-off in terms of number of patients who actually completed 3 cycles of the concurrent 3-weekly cisplatin. And you'll see again in the RDI, the relative dose intensity plots I show later, that perhaps the fact that we gave 3-weekly chemotherapy was perhaps a sort of a wise move on hindsight to be able to get enough cisplatinum into the patient and ensure sufficient dose intensity. Now, in the control arm, as you can see here, a good majority of patients completed 3 cycles of concurrent of the 3-weekly cisplatin. And this is the RDI curve for the compliance of chemotherapy during the induction phase and during the concurrent phase. And this emphasizes my point. So this is not surprising. You saw in the earlier plot that the majority of patients received 3 cycles of gemcis. The compliance rate is corresponds to the high dose intensity. Now, if you look at the concurrent cisplatin, whereby you compare between the induction arm and the concurrent arm alone, shown here in the green. And for cycle 1 and 2, a good number of patients were able to receive, the concurrent cisplatin as prescribed. But once we got to cycle 3, we see that massive drop off. And so, I think when we think in terms of, induction chemotherapy and concurrent chemoradiotherapy, it is not just induction, just in terms of optimizing control for this advanced group of patients. It is important to note that it's not just the induction, but perhaps also in ensuring adequate systemic therapy during the concurrent phase that was equally important in terms of just getting enough drugs into the patient to enhance disease control. So just a quick summary slide on the cohort here. You'll see that a majority of patients were actually very advanced T status and N status. More than 40% of patients had T4 disease. More than 50% of patients had N2-3 disease, and about 50% of the cohort comprised of stage 4 patients. And we are now aware of the difference, the results. So these were the results that was presented last year and published. You see this early difference in failure-free survival in terms of disease control, whereby again, you see a very high benchmark for disease control, even in an aggressive subgroup of patients of 76%, just with chemoradiotherapy alone. But but yet when we were able to give induction chemotherapy, we were able to achieve a 10% difference in disease control. So then this becomes the new standard of care, and this becomes a new benchmark for advanced NPC patients going forward. And how this contrasts with the Induction TPF trial was in the Induction TPF trial, our 3-year failure-free survival was about 80%. So clearly indicating that we are pushing the bar with the newer trials. And it was a nice surprise that even at a very early time point, we were able to see a difference in survival, of about approximately 5%. Now, just a point here to make. Now, you can look at this graph and say, it's great. We see a improvement in disease control, and clearly this also is an indicator of success that we're not able to push a very high bar for achieving survival even in stage 4 NPC. But you can look at it as a glass half empty, whereby just perhaps not everyone requires more chemotherapy. That even in this aggressive subgroup with just chemoradiotherapy alone, you're still able to achieve a 90% survival at 3 years. So I think it is still equally, while we're quick to embrace that this is the new standard of care, one could certainly counsel patients that not everyone requires more chemotherapy. And I think in terms of how we think going forward for designing new trials in advanced NPC patients, it's really about precision medicine, better selection of patients, enrichment of patients who are at risk, and then how do we match that to the appropriate treatment strategy. And perhaps some patients should be intensified, and some patients could be de-intensified. And I'll explain in some of my later slides how I think this space could evolve going forward. But likewise to the Induction TPF trial, we see the improvement was primarily in distant control, and we see no difference in local regional survival. So this is a slide that will summarize all the induction trials done to date. So apart from our trial, the Singapore trial, the 2 Guangzhou trials, I also showcase here the phase 2 trial from Hong Kong, the HECOG, the GOTEC trial that was not completed, and then the Taiwanese trial, and then this is another trial from Sun Yat-sen, whereby they use just induction PF alone for 2 cycles. But just to highlight some key points, we see that the population recruited differed, so sample sizes differed, and the induction use differed. The Taiwanese trial used 4 drugs, some used triplet, some used doublet, and the regimens differed. But you could see across the board that if we use induction chemotherapy, it does bring upon a improvement in disease control in an aggressive subgroup of patients who are at risk of distant metastasis. And this early difference in this disease control could actually translate to improvement in survival. And granted, the improvement in OS were based on 2 of the trials from China and the trial from Hong Kong. But the problem is that because with the emergence of all this data, when aggregated together, it's now at least offered to patients we now have a standard of care. I'll be careful to say that it is necessarily the best first line, because I know in the US, understanding from Nancy Su is that concurrent chemoradiotherapy upfront is still being utilized in a number of the centers, and I know that NRG HN001 is still currently recruiting, and we are actually a recruiting site in Singapore. But at least for patients with stage 3-4 NPC, that induction is one of the first line options for patients. Now, just as a quick note here about some of the other data that again indicates that induction chemotherapy could be the way, really be the way forward and be superior. So I can't spend time to go into this trial because it's highly complex. The paper is now published, but I just want to make a quick mention of this because this is led really by an esteemed expert that's known to many, Ann Lee, who has really been the tour de force in changing the trial landscape in NPC. And in Hong Kong, they ran this 0501 study, and the trial design is shown here. Now, the trial design is complex, but the underpinning rationale was to pit Australop, which is concurrent cisplatin adjuvant PF, against reverse Australop, which is induction PF plus concurrent cisplatin and RT. Now, what they threw in here was that to replace PF in the induction arm, they took off 5-FU and they replaced it with oral capecitabine, which we know again from the treatment refractory subset of patients whereby this drug as a monotherapy has some efficacy. And then, apart from just a 3-way comparison, they threw in alter fractionation as another sort of treatment sort of permutation to compare. And so this became a 3-by-2 comparison whereby apart from just a comparison of chemotherapy, they also looked at whether there's any difference between conventional fractionation versus accelerated 6 times a week fractionation. And if for the residents, I think if you want to look if you want to read a bit more about why this was the case, I'll refer you to the early trials, the 9901 and the 9902 trials that were done from Hong Kong to actually understand how the rationale for the accelerated fractionation came about. And the updated results were published, I think is just out in Press in Cancer. And to simplify the analysis I'm presenting here, I think there was no difference, in a nutshell, there's no difference between whether patients underwent conventional fractionation or alter fractionation. They found that fractionation did not matter, and perhaps that might be the case in the IMRT era. But it was interesting that if you just compared, patients who underwent induction, so this is patients who underwent induction PF, the orange line, and patients who underwent induction PX versus the Australop regime, they actually see an improvement in progression-free survival for the conventional fractionation arm, not so for the accelerated fractionation arm. And when they then aggregated both cohorts together, reporting on their mature data, so if you look at the first report, this difference was not emphasized, was not apparent. If anything, it was only hinted in the adjuvant PX arm, where the investigators might have seen a difference in terms of improvement in disease control, but in the updated data analysis, they found that for patients who receive induction, and doesn't matter whether it's PX or PF, when compared against adjuvant, there was a potential benefit for disease control. Now, of course, one could argue that the trial was not designed, at the beginning to look at subset analysis, but taken together with all the other studies, it does suggest that, again, induction chemotherapy, might be the way forward in terms of looking at systemic therapy intensification in the IMRT era. And this is further consolidated by the updated meta-analysis that was presented at ASCO this year. So for the updated analysis, we primarily presented the network analysis, and that was led out again from the group from Gustave Roussy, Pierre Blanchard, Jean-Pierre Pignon, and Claire Petit. And just to highlight how the trials landscape has evolved, even just within a short time period of 3 years. So this is on the left here, highlighted in the black box. You see the comparisons across the different treatments. So you get the RT alone, the different sequencing strategies, and then the nodes are reflected. The size of the nodes are reflected by the number of patients who receive that sort of sequencing. And the beauty of a network meta-analysis is that it allows you to do some form of indirect inference on which treatment may be superior for a defined group of patients. Now, fast forward 3 years later, if you look at the updated analysis, now in terms of the patients who received concurrent chemotherapy and adjuvant chemotherapy, there were more patients recruited. So this includes the 200 patients from the Sun Yat-sen adjuvant PF arm study published in Lancet Oncology. But if you then look at the induction chemotherapy, you see a massive increase in the number of patients that were treated by this treatment regimen. And that really skewed the results that you'll see later for this network and meta-analysis. Now, for the purpose of this study, the investigators further split the induction chemo cohort into those patients who received induction comprising of a taxane-containing regimen versus those who were treated without a taxane-containing regimen. And this is I will point you to the detailed analysis that were presented at ASCO this year. But in the interest of time, I'll just show you the key analysis here. And here we showcase 3 endpoints: PFS, local regional control, and distant control. And again, for the group, they actually have the individual patient data from all the different trials that were aggregated, and the treatments are ranked accordingly. And you have the corresponding hazard ratio and the p-score. But to make it easy to interpret, the treatments are ranked for each of these endpoints by the color codes here. So light blue would be the most efficacious treatment. Second would be, and then second would be green, and then third would be the yellow box. And in terms of progression-free survival, what is clear, and I'll be very careful here to make conclusions that induction is superior, induction plus concurrent is superior to concurrent plus adjuvant, because that will ruffle a lot of feathers. But I think what is clear from this analysis is that concurrent chemoradiotherapy plus adjuvant and induction chemotherapy plus concurrent chemoradiotherapy is superior to chemoradiotherapy alone. So I think for the majority of patients that we see, I think more chemotherapy should be the standard of care, and patients should be counseled for that. Now, whether they can receive it or not is a different thing altogether. But that should be the how patients are counseled. Now, we then look more specifically at the benefits by the different endpoints. Again, it's interesting to see that for distant control, induction seems to be better. So I'll leave it as that. But I think all this analysis to date will give rise to much more hypotheses. I think they've certainly helped in terms of advancing care and standards for our patients. I think they're also fascinating because it shows that despite after so many decades of trials that have been done, that our understanding of this disease continues to evolve, and how we should sequence strategies, and how that would actually result in efficacy for the different clinical endpoints. And then in the era of immunotherapy, how do we best sequence it? And I think that will be something that we'll discuss in the Q&A later.
In part 2, Dr. Chua picks it up from here. He'll go on to next generation trials, a discussion of oligometastases, and engage in a Q&A session. Hope you can listen in.